My name is Dr. William Drew, and I am the Pet Engagement and Delivery Manager for the UK's National Total Body Pet Imaging Platform, NPIP. Long axial field of view and total body PET systems represent one of the most significant advances in imaging technology in recent decades. With dramatically increased sensitivity, reduced administered doses, and the ability to capture dynamic biological processes across the entire body simultaneously, these systems are redefining what is possible in clinical research and translational medicine. Around the world, total body PET is reshaping how we investigate disease biology and evaluate novel therapeutics and design precision medicine strategies. NPIP has been established to ensure that the UK plays a leading role in this transformation, enabling collaborative research, accelerating clinical translation, and building the infrastructure required to harness the full potential of next-generation PET technologies. We're therefore delighted to be joined today by two internationally recognised leaders in medical imaging and nuclear physics, Professor Stephen Meikle and Professor Dale Bailey, who have been instrumental in advancing the total body PET imaging within the Australian programme. Professor Meikle is Professor of Medical Imaging Physics at the University of Sydney and Head of Imaging Physics of the Imaging Physics Laboratory at the Brain and Mind Centre. He also holds senior leadership roles within Sydney Imaging and the National Imaging Facility. His work focuses on advancing PET and SPECT instrumentation and methodology to push the limits of sensitivity, spatial resolution, and quantitative accuracy, and on translating these advances into a deeper understanding of disease mechanisms and novel imaging biomarkers. Professor Dale Bailey is a physicist specialising in nuclear medicine with appointments at the Royal North Shore Hospital and the University of Sydney. He has been a pioneer in quantitative functional and hybrid imaging, integrating structural and physiological information within a single scanning session. More recently, his work has focused on radionuclide therapy, particularly personalised dosimetry and understanding the biological effects of radiation to optimise patient outcomes. Today's discussion provides an opportunity not only to learn from Australia's experience, but to also reflect on how international collaboration can accelerate innovation and maximise global impact of total body PET. We're very pleased to have you join us today and look forward to a stimulating presentation and discussion. So before I hand over to Professor Meikle, I'd like to remind you to please submit any questions that you may have into the Q&A box at the bottom of your screen, and we'll aim to address as many of these as possible following the presentations. Professor Meikle, I'll hand over to you now.
Thanks, Will, and thanks for that kind introduction. Good morning to all of our colleagues in the UK who are joining us for this webinar, and good evening to our Australian colleagues. So, yes, as Will said, we're going to give a little overview of our total body PET facility and how it fits into the national context here in Australia. So just to kick that off, I'll give you a bit of an introduction to our facility. So this is a photograph taken at the launch of our facility in December 2023. It was funded by the National Imaging Facility together with our institutional partners, the University of Sydney and Northern Sydney Local Health District. And you can see representatives of those three partners in the foreground there cutting the ribbon. This is a partnership between the university and the Northern Sydney Local Health District, and I'll talk a little bit about how that works in a moment. And as you can see in the background there, this is a Siemens Biograph Quadra. So before I talk about our facility, I'm just going to talk about the national context and how we fit into the National Imaging Facility. So the National Imaging Facility is a network a little like NPIP, and its raison d'etre is to provide open access to flagship imaging equipment, expertise, tools, data and analysis for our broader research communities. You can see from the numbers there on the left, it comprises over 190 imaging scientists who sit alongside 105 advanced imaging instruments covering a whole range of imaging modalities, both preclinical and clinical. And those facilities are located in 14 institutional partners across Australia. So here's a map of Australia just showing the footprint of NIF. with the color coding indicating the different imaging modalities. There are many others as well. And this is where we are in Sydney. And the total body PET facility I'm going to be talking about is located at the Royal North Shore Hospital. So this is just a capture of all the human molecular imaging systems, research systems we have around the NIF network. And I just wanted to highlight the three total body PET systems, which form a mini network within a network, if you like. So you can see our Siemens Quadra on the left there. We also have now the GE Omni system at the Peter Mac in Melbourne. So this was the first long axial field of view Omni system, 128 centimeter axial field of view. And then there's also another Siemens Quadra at the Alfred Hospital, also in Melbourne, which is part of the Monash NIF node. So that network allows us to work together collaboratively on capacity building for multi-center clinical trials and topics like harmonisation of quantitative metrics. So just a little bit about our operating model now. So coming back to our own facility in Sydney, it's an equal timeshare arrangement where the capacity is shared between clinical and research operations. Clinical support across both research and clinical is provided by Royal North Shore Hospital clinical staff, and the research operations are managed by the Sydney Imaging Core Research Facility. So by default, the scanner is used in the mornings for clinical operations up until 1:30 p.m. and then at that point it's handed over to the university for research scanning. And there's a fair bit of flexibility in that operating model, but that's the default arrangement. And if you want to know anything more about the operating model, how we make this work, and what we see as the benefits of this model, we published this article in the Journal of Nuclear Medicine last year. So I'm going to just give a very high-level overview of our research program, which comprises mostly clinical trials and cohort studies. So studies looking at things like new imaging protocols, novel therapeutics, new radiopharmaceuticals, and hopefully some blue sky applications. And I'll show you an example of one of those. We also have a very busy methodology program looking at challenges in total body PET. Some of the projects I'd describe as bread and butter. Developments like ultra low dose imaging and harmonisation. I'll show you again some examples of the former. And then also some more cutting edge projects looking at things like the use of generative deep learning for kinetic modelling and parametric imaging. And we're also interested in molecular connectivity studies. And I won't talk about the radiochemistry program in today's talk. So just an overview of our project pipeline. So we have 25 projects on the books to date, coming from 6 unique institutions. And you can see from that, and 20 of those projects are currently actively recruiting and scanning. You can see from that second pie chart that they're mostly clinical trials and what we call low risk clinical trials. So they're really cohort studies that don't have a health intervention. And then the third pie chart, you can see that most of these studies are coming from the university and the local health district. But we also have projects from elsewhere in Australia and international collaborators. And then on the far right, you can see the distribution of the fields of research that are covered by those projects, with oncology and neuroscience dominating. So I'm just going to pick out one of those projects that we're excited about because we think this is quite a new application area for PET, and that's heat stress and acclimation. And this is a total body, an FDG dynamic total body PET study. The PI is Ollie J, who heads up the Heat and Health Research Centre at the university. So what we're doing here, so obviously the aim of this study is to evaluate the ability of the body to cope with heat stress and to acclimate to heat stress exposure. So on day zero, these subjects will have a scan under normothermic conditions. These are healthy subjects, and they'll be wearing a bodysuit that has tubing that goes all the way through the suit and is connected to a heat exchanger. So 2 days later, they'll have a repeat scan. So these are 1 hour dynamic scans. But in this case, we'll heat the bodysuit up to 50 degrees C. And the aim there is to raise the core body temperature by 1.5 degrees C and maintain it throughout the scan. So we call that our pre-acclimation data set, and we'll process those studies to calculate flow reserve and metabolic reserve in all the major organs of the body. I'll talk in a moment about how we do that. Then these subjects will undergo heat acclimation, so they will perform high intensity exercise for up to 2 hours in a heat chamber that's heated to 40 degrees C at 75% humidity. That program goes for 7 days, and then on day 10 and 12, we'll repeat the dynamic PET scans and once again calculate flow reserve and metabolic reserve under normothermic and hypothermic conditions. I won't be able to show you any results of this study just yet, so I'm sorry to keep you hanging there, but if you're coming to the Total Body PET conference at UC Davis later this year, we will be presenting about this project there. And if you're wondering how we can get flow reserve and metabolic reserve from a single FDG dynamic, the plan is to use the methodology developed at UC Davis. So we're collaborating with Guabao and Kevin and others. And what they showed very elegantly, I think, is that with the vastly increased sensitivity of total body PET, you can do very rapid temporal sampling in the early delivery phase of the tracer. And when you do that and you apply a distributed kinetic model like this one shown in the bottom right here, this is the adiabatic approximation model, you can extract vascular blood flow directly from your kinetic modeling. So this is a model that takes into account the finite transit of the tracer across the vasculature serving the tissue. And as I say, it estimates blood flow directly from that first 2 minutes of the study. And the UC Davis group showed very nicely that this method correlates very tightly with measures from a pure blood flow tracer in C11 butanol across all the major organs of the body. So that's how we get both flow reserve and glucose metabolism from the single scan. So moving on to some methodology. This is some work performed by our total body PET fellow, Yorgos Angelis. And so he's done, a very thorough study of a whole range of low-dose CT imaging protocols. You can see the protocols there on the left, the CT scans of image quality phantom on the left and the corresponding PET scans of the same phantom on the right, using attenuation correction from those CT scans. And I won't go through all the details of the protocols here, but you can see that some of them produce rather noisy, quite noisy CT scans, and in some cases, photon starvation artifacts. But looking at the PET scans qualitatively, you really can't see much of an impact on image quality. And then these are the quantitative results on the right here. So again, just picking out the details, the high level details here. So these are the CT Hounsfield unit values in the top graph in red, and the variability is the shaded area. The grey curve there shows the CT dose index decreasing for these various protocols. And below that, the PET SUV results showing that the SUV is very stable and largely unaffected by the choice of CT protocol. So you can get down to very low doses and still get very high quality and accurate PET images. So we chose this protocol as a kind of nice trade-off between image quality and low dose. So we use 6 MAS and a 140 kVp tube potential with a tin filter. So that's the protocol we moved forward with to do a clinical study. And these subjects, were clinical patients who had an additional CT scan, the ultra low dose scan, in addition to their standard CT protocol. And you can see the difference images for the CT scans, the attenuation factors, and in the bottom row, the PET scans. So I'll just pick out the main highlights here. So looking at the differences between the PET scans processed with the two CT protocols, really the differences were less than about 5% throughout the body, except in this region around the diaphragm, the dome of the liver, where we put those differences down to respiratory mismatch due to the fact that the patients had two different CT scans at different times. And then these results here are represent the SUV max bias in about 50 anatomical regions across 27, I believe it was, patients. So the box on the left is all the FDG scans, and the box on the right is the gallium dotatate scans. And once again, the SUV bias is very small, within about half an SUV unit, except in this region, which also corresponds to the diaphragm. And then finally, Yorgos inserted some simulated lesions into these clinical scans and showed that the lesion detectability is, again, not significantly different between the two CT protocols used for attenuation correction. And that is reflected also in the area under the curve of these ROC curves for a channelized Hotelling observer. And then Dale will talk more about how we've used that methodology in clinical studies. I just wanted to briefly mention as well a more, I suppose, cutting edge development, which is the work of our postdoc, Yun Xiao. So he's been working on the development of generative consistency models. This is a type of diffusion model. And we're using this for kinetic model parameter estimation. So I won't go through the details here, but like other diffusion models, the idea is to start off with a completely noisy initial estimate of your kinetic model parameters. So they're the model parameters there. And the aim is to predict the final kinetic model parameters. And it's that prediction is obtained through this mapping function, f theta, and it's conditioned on the time activity curves y. So that's what y represents there. And the theta in this mapping function represents the trainable parameters in a deep neural network. It's a 1D UNet, and I won't go into the details of the structure or the way we train that model in this talk. But so that's the general idea. Consistency models get us to that prediction in just two very short, computationally efficient steps. And then we repeat that sampling up to 1,000 times to give us 1,000 different starting estimates, all based on Gaussian noise, and 1,000 different predictions. And we can then sum down the columns and obtain a histogram of all the kinetic model parameters. What that gives us is an estimate of the posterior probability density for each of those model parameters. And I'll show you on the next slide why we think that's extremely useful. And this is the transfer function that the model has to learn. So these are the outcomes from that method when you apply it to every voxel in a total body PET dynamic. This is an FDG dynamic scan. So we get a parametric map of Ki on the left here. So that comes from the posterior mean for each voxel and each parameter. So that is roughly comparable to a PATLAC KI parametric map. But the nice is it also gives an uncertainty map. So the voxels in this image represent the width of the 95% credible interval for each of those model parameters, in this case KI. So you can see, for example, that the uncertainty is very low in the tumor here in the liver. In addition to that, it also gives us the ability to test different kinetic models for different organs and tissues. So we can produce a model probability map. And here are the posterior probability densities for selected regions of interest. So it gives us a lot of rich information. And just to finish on this method, so that model was trained on FD genetic, and it does take a lot of training, 500,000 training pairs, and takes quite a while to train, a few days to train that model. What we wanted to know, however, is can it be generalized to other situations such as other traces and other imaging protocols? And so we've used a technique called low rank adaptation, which is kind of a way to bolt on these fine tuning components to the model, so that it can it's like a transfer learning technique, so that it can learn to adapt to these other traces and protocols. And so far, the results are very promising. Sorry. So just very quickly, we've taken that model, we've adapted it to a completely different tracer. This is FPCIT, a dopamine transporter ligand, and you can see where the reference method we're using here is MCMC, the blue distribution. So it matches the reference very well and produces very nice images of binding potential, which agree very well with standard kinetic modeling techniques. We've also tested on different sampling schedules and reduced duration scans and high temporal sampling. So it looks like a very promising technique. So I'll just sum up by saying in our hands, we've had about 2 years experience now with this facility and this technology. We think it's a very powerful translational research tool. And we believe as well that this 50/50 operating model works extremely well for us and helps with rapid translation of new findings. We think there's also a lot of potential to expand the range of PET applications and reach new clinical populations. And Dale will show you some examples of that. It also introduces a number of new methodological and data science challenges, which I've touched on. And it also introduces an opportunity to form collaborative total body PET communities through national and international networks like NIF and NPIP. So I think there's a lot of opportunity there as well. So thanks for your attention, and I'll hand back to Will.
Thank you, Professor Miko. So we'll now move from innovation in instrumentation and methodology into some more clinical translation examples. So Professor Bailey, if you're ready to share your slides.
Thanks very much, Will. Yes, Steve set the scene very nicely for us, and I'll talk more about the clinical side of things, and I think you'll see how this joint operation is really benefiting both the patients and the research. So Royal North Shore Hospital is a tertiary referral hospital, and we have offer all sorts of clinical treatments that you could imagine: neurosurgery, radiotherapy, medical oncology, and so on. And we are a large teaching hospital of the University of Sydney's Medical School. We previously had a standard analog Biograph MCT scanner from 2010, and we used to scan about 14 or 15 patients a day on that. And when the university approached us about this different model and how we might integrate with the research into our environment, we had to think about it and decided that what we would do is we would offer to run the facility for the university, and we would try and keep the same number of patients a day as we had currently been scanning. So that meant we could try and get all of the scans, clinical scans, done in the first part of the day, and then give the system over to the university where we would continue to run it. So you can see here on the slide that what we try and do is get somewhere between 16 and 20 patients done between when we start up at around 8 o'clock, the first injection, through to about 1:30, and then we leave it to the university to do their research studies. Steve's pointed out a couple of things that they've been doing methodologically, and it's worth emphasising at this point that having clinical patients in the research environment helps the researchers because, as you know, if your first scan of the day is a FDG scan, you inject the patient, you wait 60 minutes, and then do the delayed imaging. But we've been able to take our clinical patients and ask them, rather than sitting in the uptake room in a comfy chair, to lie on the bed and have a 60-minute dynamic, and there's no extra radiation involved. And so we've been able to get the first patient of the day often to provide data that's been of great use to the university in terms of developing the models that Steve spoke about. Similarly, the work that Yorgos has done with the ultra-low dose imaging, we've been able to apply directly to our patients. And so there's been a nice two-way street there in swapping research capabilities and our resources. And in my mind, having equipment like this in the larger teaching hospitals is the ideal place to have it, because that's the interface between the clinical patients and the cohorts of different types of patients and the researchers. And that's really where you want it. You don't want it locked up inside a university somewhere where patients have to go out of their way to go there. So you can see our model there, and Steve alluded to, but we go flat out in the morning. But while I say flat out, there are 15-minute bookings at the moment for all patients. The PET scans are 5 minutes, and it's actually a rather relaxed timeline because giving yourself 15 minutes with a 5-minute scan for PET does allow a lot of time on either side to prepare the patients, get them on and off the bed, and so on. Now, we are a non-cyclotron facility. The head of department, Paul Roach, and myself both decided a long time ago that we did not want a cyclotron and all of the overheads and the financial pressures that brings. And so we were happy to exist on fluorine-18 and gallium-68 for most of our work. And what I'm showing you is the PET radiopharmaceuticals that are available at our hospital today. Now, most facilities in Sydney would provide you with FDG, of course, and probably a gallium peptide and gallium dotatate for neuroendocrine tumor imaging and gallium-68 PSMA. That's pretty standard, but you can see that we've gone way beyond that with one hot cell to do fluorination and a couple of cassette-based systems to do the gallium peptides. So we offer quite a wide range of radiopharmaceuticals now for PET. And I'm going to show you a couple of ones that we do offer in addition to most others. These are only available at our site in our state of New South Wales at the moment. And just to show you how we're using total body PET with these. So the first one was a request from our endocrinology department. Could we help them to localize insulinomas? These are very difficult and potentially life-threatening tumors, which can cause hypoglycemia and by the high insulin levels that are excreted. And so very typically hard to find on morphological imaging, CT or MRI. But you can see, everyone can notice here where this insulinoma is located, and that's the only lesion of uptake in the body. Now, this is targeting the GLP-1 receptor, which of course is the same as we know about today with Ozempic and the other weight loss drugs that we hear so much about. It's the same target, but here we've isolated this patient's lesion, and the surgeon can go in and remove that very easily. Another one, and this is starting to talk more to the power of total body PET, is in fluorocholine imaging. Here we're looking for ectopic parathyroids, typically adenomas, and these cause hypercalcemia and primary hyperparathyroidism. And so the imaging agent of choice here is fluorine-18 fluorocholine. We don't make that at the moment, but we intend to soon, but we can import it from another centre. And so we do a quick dynamic study for 20 minutes. And from that, we've been looking at PATLAC analysis. So what I'm showing you here is the standard sort of imaging you would expect in most centres, a delayed image 60 minutes after the injection of the fluorocholine. And you can see I've outlined a lesion there just beyond the above the sternum. And that's a parathyroid adenoma. We also saw it at 15 minutes in the early imaging, and that's been reported in the literature as well. But we've been looking also at doing a KI map of this, so looking at the influx rate constant KI in the dynamic of the first 0 to 20 minutes. We're doing 1 minute frames here, and we get the input function for the Patlack model from the blood pool, the left ventricle of the blood pool, because that's in the field of view. And this is one huge advantage with the total body system, that you don't have to pick where you want to image for a regional imaging of an organ and give up an input function. You've got the heart in the field of view, and you can derive a very decent input function from that. And you can see here that the imaging from KI is very good also, equivalent really to the delayed imaging. Here's another example showing something a little bit different, where the 60-minute imaging showed some uptake, which you could, with the help of the CT scan, work out that it's in a rib and it's not. It's a non-specific finding. It was faintly visible at 15 minutes, but interestingly, in the KI map, it showed that there was no specific uptake into that. And so this is not a parathyroid adenoma. This is just some non-specific uptake that you can see. And the same patient, another example where there was something seen in the supraclavicular fossa at the 15-minute image, and it disappeared by 60 minutes. So that would indicate that it's not a parathyroid adenoma, but also that was reflected in the KI map as well. So we are able to do some of these studies, although dynamic studies, of course, increase the time the patient's on the scanner. Those 60-minute images you can see are only 5-minute images, so it does take more time, and that's just something we are aware of. We've applied this also to gallium-68 PSMA dynamic imaging, where we do a 10-minute dynamic from acquisition with 20-second frames. And the image on the left is the standard delayed static image at 60 minutes. And the image on the right showing you all the metastatic disease as the KI map. And that vertebral lesion that's highlighted there is equally well seen in both. And so we looked at a series of about 40 patients and comparing the KI map from the early 10-minute dynamic with the delayed scan, and really didn't see any differences. It also does remove the bladder in the early imaging and from the Patlack, so that's actually quite a nice feature. Steve mentioned Yorgos's fantastic work with ultra-low dose scanning, and so we've been able to use that. We were asked about a year ago, could we do any FDG scanning in pregnant patients, because the staging information from PET is so important there. And so we were able to use a combination of what Yorgos had done and what we've been working on. We have reduced the dose of FDG from what we previously used to give with the previous MCT scanner from 250 megabecquerels down to 150 megabecquerels. And so our standard protocol is everybody gets 150 megabecquerels and gets a 5-minute scan for FDG. So what we did here was to reduce that amount of FDG administered to 40 megabecquerels, so down to about a quarter of the dose. And we increased the time from 5 minutes to 20 minutes for the acquisition to offset that reduction in the administered FDG. So you can do this with total body PET because of the incredibly high sensitivity you have and the short standard scanning times. But you couldn't do this with a standard, even a digital PET camera today, because a 15-minute scan, for example, whole body would still take you 60 minutes if you had to increase it by a factor of 4. So this is the sort of flexibility that you get with the total body system. So there's an example of a ultra low dose CT of about 0.4 millisieverts effective dose. That's that whole body CT, and then about 0.8 millisieverts from the 39 megabecquerels of FDG injected. Image quality is, as expected, outstanding. Another couple you can see here, lymphoma case on the left, and then 2 other breast cancer patients of unfortunate young women during pregnancy who've had a diagnosis of gestational cancer. But this is very helpful data for, obviously, for the oncologists managing them during the pregnancy and beyond. And another example, there's another parathyroid adenoma scan on the right-hand side there, stopped at the level of the umbilicus, of course, to reduce the dose to the fetus, because we know that these adenomas are usually found somewhere in the thoracic cavity or above. So when we started to learn how to use this machine, the thing that became really obvious to us is that what it gave us compared to our previous generation machine was flexibility. And the extra sensitivity and the total body coverage is really a game changer in terms of giving you this flexibility. So you get your faster imaging. So as we started off, we used standard doses. We looked at how much we could reduce it by. I think you can see there that reducing scan time, we really weren't losing any quality at all. So we were able to come up with a compromise of reduced dose plus reduced administered activity, reduced dose to the patient, and also reduced time. So that low dose we fixed on was to reduce our FDG standard injection by 40%, and 150 megabecquerels is standard across the board. With time of flight, we've known this for a long time, that you preserve signal to noise across different patient sizes. And so with this very fast time of flight on the Quadra system, we really don't need to change our administration protocols at all based on the patient's size or weight. And this also, of course, gives lower radiation doses to the patients, particularly for pediatrics, pregnant patients, but also it reduces the exposure of the staff. So Steve's talked a bit about this, and I've mentioned this with the whole body dynamics. You can do those fantastic kinetics of the whole body using a great input function that you can see from the left ventricle, and then doing it on a voxel by voxel basis. And that's some PSMA work, as I mentioned there. You can see in the left-hand image, the cross-sectional image, the KI map, the real absence of the bladder at that stage, having been removed by the model, and also the slow appearance of radioactive urine in the bladder compared to the delayed image on the right-hand side. The X-ray dose reduction using the tin filter and the CT methodology that we all know about can really reduce this down to very acceptable levels. And so not only is this important in sensitive patients, but also if you were doing serial studies in patients where you might want to image them, say, with zirconium over a number of days, or copper-64 extending out for a few days, you can choose to do one of your standard low-dose CT scans for the image quality that you want, but the rest of them can use ultra-low dose. So that's reducing the dose for the CT component from about 4 to 6 millisieverts each imaging session down to less than 1. So that really does make the radiation safety committees a lot happier, and we're always looking to reduce dose if we can. And we don't need those higher quality CT scans at every time point. We've got fantastically improved image quality, and this was one patient that we were lucky to capture over a limited time, less than about 8 months. And this patient was incredibly stable. You can see she had a couple of lesions in her hilar area. This is FDG, of course. And then with 3 different generations of scanners, you can see the 2 analog systems, the MCT and Horizon, everything looked pretty stable. And then when we come to imaging on the Quadra, not only do you see that lesion that we believe has changed, you see it better defined, but also look at the abdomen and the definition you get in the abdominal vessels, the abdominal aorta and the vena cava, compared to the previous scans. Also, look at the uniformity of liver compared to the previous scans. And so across the board, there's this terrific improvement in image quality. And again, that's a 5-minute scan with a reduced dose. We are doing a trial looking at doing both gallium-68 imaging and FDG imaging on the same day. We are huge proponents of dual PET in cases like PSMA and neuroendocrine tumours for fully characterising the patient's disease. We refer to it as being like a whole body biopsy, where we can look at different phenotypes of the disease being expressed in different parts of the body. And now we can play a game such as a half dose of gallium first thing in the morning. Instead of a 5-minute scan, we do a 10-minute scan. And then a couple of hours later, we can inject them with FDG and exploit the half-life and the washout of the gallium-68 peptide to reduce the crosstalk that will have. At the moment, we're doing a trial where we're doing the imaging separate and combined in a protocol designed to have a look at the crossover. But we think that we're going to be able to do this, and this greatly reduces the financial toxicity for many of our patients who might have to come from regional areas and stay overnight. One night, get a PET scan the next day with, say, gallium dotatate, stay overnight again in a hotel, come back the following day, have FDG scan, and then they go home. They miss 3 days off work, and so on. We can reduce that hopefully to 1 day. We can do a lot of later time point imaging, of course, with the higher sensitivity of total body PET. And here's some images from a trial that we're running looking at redifferentiation of radioiodine-resistant thyroid cancer using tyrosine kinase inhibitors. and you can see an image on the left there, 24 hours after the oral ingestion of 40 megabecquerels of iodine 124, a PET radionuclide, and then about 6 days later, or 5 days later, still following that patient out, and we're using this for dosimetry estimations. The image quality is still tremendously good at that point in time. So this does open up a lot of later time point imaging. Frankly, these systems are exceptional, and the model we have, the funding came about because our federal government, through the National Imaging Facility, gave us approximately 50% of the funding. The university and the hospital split the remainder. But what that meant for the hospital was that instead of buying a standard state-of-the-art PET-CT system of a single field of view, we were able to put the money towards this and offer this to our patients. So we've really benefited tremendously as the clinicians using the system, but also the patients love it. So the advantages for us of total body PET in the clinic include reducing that amount of radioactivity, so reduced exposure to both the patients and the staff. We've had huge savings. It equates to something like 250 to 300,000 British pounds per annum off our radiopharmaceutical budget. And also we can get more gallium-68 scans out of a single run on our synthesis system for gallium-68 dotatate or PSMA or any other gallium peptide like Exendin-4. And these can often be reasonably expensive syntheses to run, but now we can get, rather than 3 or 4 patients, we're talking about 5 or 6 patients per synthesis. We've reduced our scan times enormously, and we're probably going to go shorter again, therefore higher throughput. And really the patient compliance, even though it's a total body system with a longer tunnel, has been terrific, and the patient's approval has been outstanding. We really haven't had anybody who hasn't thought that this was better, and we actually have many patients now who want to come back and have their scan here rather than on a standard system somewhere else. It's also giving us new approaches to scanning not otherwise possible. I'm very interested in the dynamics, the early dynamics, and whether they perform as well as the delayed statics, because that really flips the whole paradigm for clinical imaging. So the PSMA patient might come straight from the waiting room, jumps on the bed, has an injection, 10-minute scan, and then out the door and sent home. So no 1-hour uptake and delayed imaging and all the rest of it. So I think that's a really interesting thing, and you can only really do with total body PET. And with the ultra low dose, we're able to obviously get into areas such as staging in pregnancy, which is really very helpful for the patients managing their condition. So we think we've got a bright future ahead of us with this. And I would really emphasize what Steve said as well about the combined operation. It's a great model. We feed them with our clinical patients for research work. They do developments which we feed back into the clinic to benefit the patients. And I think the model not only works for something, an imaging device like PET, but I think of things we look at it in the hospital we'd like to get, such as next-gen sequences, but we wonder if we can justify the cost in terms of the clinical load. But if there's also a research question, then that sort of device could also be used in that sort of environment. So thanks for your attention, and we'll hand back to Will.
Thank you so much, Professor Bailey. So we have about 10 minutes for any audience questions. So I can see there's some starting to come into the Q&A box. So please continue to post those, and we'll work our way through as many as possible before we close the webinar. So the first question we have submitted is specific to your talk, Professor Bailey. So maybe you could reflect on this one. So whether there are any weight loss effects observed during the GLP receptor tracer study?
The answer is no, but we've added something to our questionnaire for standard FDG scans, asking the patients if they are on the GLP-1 receptor agonist, because we think that might be changing the biodistribution of the FDG. So it's not directly coming from the Exendin imaging, because that's really looking for a focus of high insulin production. But the whole issue of GLP-1 is something that I think we all need to be aware of with FDG imaging.
And could I just add to that? So that question came from Terry Dale, and he was also asking about research around these GLP-1 tracers. And just to say that, Terry, we've had a lot of engagement with the metabolic disorders researchers on campus, and they're certainly using PET imaging for their animal models. But we haven't quite got the right study up and running just yet to translate that to human subjects on the total body PET. But I think there is a lot of potential there. Absolutely.
Thank you, both. So, second question. This question's about the 50/50 sort of time split across your total body PET capability. So, it's a question around the setup of this on one of the UK sites, and the plans is to kind of put together the research and clinical time, not so as I understand the question, not so abruptly split into a morning session and an afternoon session to more interweave them together. So I was wondering if you could comment a little bit on sort of any challenges around the variability of when the research traces are available and how that's impacted your plans to have a 50/50 split in the day.
From the clinical perspective, Steve, I guess when the clinic is running, we really need to punch the patients through very regularly. So it's got to be really on the money the whole time. Um, Research patients can be more problematic in times and need more stabilization or interventions and things like that. So our initial model has been to split that time quite clearly, although every now and then there's a little bit of horse trading. We move back and forwards, and we can get delayed scans. We can get patients with high blood glucose levels that we need to bring down before we can do our scan, and that might slip into the afternoon. But the university then compensates by taking time the next day, and so on. We think in the future we'll probably need to even integrate more, but at the moment it's been working pretty well, and it also makes it very relaxed for the university. We're not breathing over their shoulder saying, "Are you finished? Have you finished? Can we get our patient on?" So it really makes a nice clean break, I think, at the moment. And I just really applaud the university for having the vision that not to put this in the university in a research building, but to put it in the hospital where the interface is with the patients. So we have all of the infrastructure support. And when you start to think about it, when we started to get into this, you needed things like teams that could respond to cardiac arrests, contrast allergic reactions. You needed emergency access as well. Patients can these Extendin 4 studies can actually go hypoglycemic on you, so you have to have dextrose on hand, nursing staff, typically an endocrinologist or an endocrinology fellow to manage those as well. I know we say we do tracer studies, but this is the only study I've ever seen that can actually, the injection of the tracer can tip the patient into a clinical condition which might induce a hypoglycemic coma.
Thank you. Do you have any other comments on sort of the sort of more operational side of this 50/50 split that you operate?
Well, maybe what I would add to what Dale said is that split with clinical in the morning, research in the afternoon, it works very well for us because we get a lot of our isotope and/or tracer from commercial suppliers, and they tend to produce, the clinical supplies of FDG first thing in the morning. And if we're wanting to make tracers in-house, we're reliant on them as well for F18. As Dale said, we don't have our own cyclotron. So in general, that supply comes later in the day. So it just sort of works well for us. If you have your own cyclotron and you're completely in control of your own radiochemistry program, then you might be able to work a lot more flexibly, like Luigi says in his question, according to the availability of tracers. But it works well for us just because of the way we receive FDG and F18.
Thank you both. We'll move on to the next question on the KI maps. So from
Yeah,
Christine
so
Parker.
Christine's asked a question about missing lesions. I think with peptides, Christine, our observation is that the uptake is extremely rapid. I think they probably peak within about 3 minutes of injection. And then what we're doing by waiting for delayed scanning is just trying to reduce the blood pool background. by excretion, typically through the kidneys. So the KI kind of takes that out because you split that dynamic into the VD component and the KI component. Is there a risk of missing any lesions? Look, in all honesty, we had 39 patients. We missed one lesion, which was a tiny vertebral lesion, which was seen on the delayed image of PSMA, not in the dynamic. And we had the good fortune to be able to follow that because these are clinical patients. The patient came back 12 months later, and the disease had just exploded everywhere. And sure enough, that lesion that was seen in the delayed image was also seen now as a sclerotic lesion that looked like it had burnt out, actually. I think we missed one. That's one out of 39 patients and probably 300 or 400 lesions. So I think it worked pretty well, but it's still very much experimental at this stage. But I'd really encourage you, if you have the opportunity to do dynamic studies, to look at this because it's very straightforward to do the modelling using the left ventricular input function that you get.
Thank
About the
you.
low PT protocols being supported. Steve, correct me if I'm wrong, but I think Siemens would be very happy to promote this, and we're kind of doing the proving for them. And others have reported these sorts of techniques as well and methods. And yes, we would certainly support it and provide those also.
Yeah, yeah. There's a number of sites around the world that are all working on ways to share data, share methods, share protocols. I wouldn't say it's all been sorted yet. The biggest barrier is interinstitutional data sharing agreements, but we've done that with a few different sites, and we've managed to share data. A lot of the methods we develop are open source. We put them up in GitHub repository. So yeah, there's not too many barriers to doing this, except for just the size of the data sets, really.
And where do we see
Thank
the
you.
value of national collaboration for TB PET? I guess Steve and I both would have views on this. Um, I think it would be in generating normal databases of the traces we use, typically FDG. I think it's very hard for any of us as individual sites to probably generate the range of patients or normal subject sizes and things um, for normals, and given that we're using ionizing radiation as well. So I think if we combine internationally and each contribute 2 patients or 5 patients, then we might get a pretty strong data set. But Steve, you've probably got other ideas as well.
My ideas are pretty similar, and I think that's actually one of the more important things that the two networks could do together, NPIP and NIF, is to pool data. There is an initiative from NIF to do exactly that, to set up ways to collect valuable data for reuse in research studies and share it. So I think that would be a really nice initiative. And I know that the Americans are trying to do similar sorts of things. So yeah, I agree. I think that's where you get a lot of value. And I think if we could get our heads together and our facilities together to produce a series of total body PET scans across more than a few traces in normal, healthy individuals across the lifespan, that would be an amazing data set. It's not easy to collect and compile and curate a data set like that, but I think that would be very, very valuable.
Jessica's got a question about the protocols and the importance of having machines in the clinic. Yeah, Jessica, I could not overemphasize how important this is to have the machines in the clinic, unless you've got an incredible research program that needs them all the time. But I didn't mention this, and perhaps I should have made the point that not only are we working together, as you can see scientifically, but we're sharing the risk, we're sharing the finance, we're sharing the maintenance costs. And so from our hospital's point of view, we've got this amazing machine producing outstanding quality images, and it's cost us no more to purchase than the standard field of view PET, and the maintenance contract works out about the same. We really are in a great position of having a total body PET for the price of the standard system, and we haven't moved the protocols yet, to other sites because one of the other there's only three other quadras in Australia, and they're busy clinical places as well. We've certainly let them know about it, but one of them's a research centre only, and so we haven't they haven't asked for it yet. But we certainly talking to the last installation in Australia, the Quadra. They're definitely interested in doing this as well.
Thank you. Maybe we could comment. Maybe the remaining question in the Q&A box is about cross-site studies, cross-site trials, and whether you've got plans to do any harmonisation across the data that's shared, and especially where different scanners might be involved.
Yeah, we certainly do. So that mini network that I referred to, so the three total body PET sites that are part of the NIF Human Molecular Imaging Network. We have some projects that are funded by NIF to address the issue of harmonisation. So I don't know if you recall, but one of those three is a GE, the other two are Quadras. So there's an issue right there just about making sure that if you scan a subject under the exact same conditions across those three scanners, you get the same SUVs, KIs, K1s, K2s, etc. We're actually extending that. So that harmonisation work it's only just beginning. But the aim there is to make sure that those systems and those facilities can participate in multi-centre clinical trials. And we also want to harmonise across PET systems because there's quite a number of PET scanners in NIF that are not total body PET as well. And then we're also extending that to connectivity metrics as well. So there's a few sites that are starting to look at molecular connectivity, and we want to make sure that that methodology is reproducible and that the outcome measures are consistent across sites as well. So yeah, we're putting a fair bit of effort into that, and there are international partners that are keen to work on this as well.
That's great, thank you. So I think it's time for me to close the webinar today. So I'd like to thank you all for joining us today in the fourth webinar of the National Total Body PET Imaging Platform Series, which has been exploring how next generation PET technologies are reshaping clinical research and practice. I'd like to extend my sincere thank you to Professor Meikle and Professor Bailey for sharing their expertise and experience in this webinar today. Your insight has highlighted both the scientific potential and the translational impact of total body PET within the modern healthcare system. We look forward to welcoming you to our next webinar in the series, which is on the 14th of May, which will feature Phil Murphy, who's Head of Imaging and Digital Health at Johnson & Johnson, and also Natasha Patel from the Oncology Imaging team at GSK, who'll provide an industry perspective on total body PET imaging. The registration details for this webinar and the recordings of the previous webinars are also available on the MPIT website. So I'd like to thank you again for joining us today, and we look forward to continuing the conversation in the next webinar. Thank you.